Good afternoon, everyone. Welcome to the Foundation for Opioid Response Efforts webinar series on maintaining access to OUD treatment and recovery services during the COVID epidemic. I'm Karen Scott, President of the Foundation for Opioid Response Efforts. FORE is a national private foundation supporting solutions to the opioid crisis. As some of you may know, over the past several months, we've developed a series of webinars to highlight the immediate challenges to maintaining access to OUD treatment during the pandemic and practical experiences and solutions rapidly evolving around the country. Today, we're going to pivot a little bit and begin to focus on what we can learn from the past 6 months as healthcare providers responded to the requirements of safety during the pandemic, relaxation of some regulations, and the potential for innovation in care delivery. FORE's aim is to support work on bringing these lessons learned into discussions about how we can improve access and quality of OUD treatment for the long term. The impact on opioid treatment programs is particularly worthy of a specific focus given the specific regulatory requirements governing the delivery of methadone. You'll hear from our panel of presenters today, beginning with findings from a project we funded our RAND researchers to conduct, hearing from frontline providers, and closing with comments from 2 national leaders in the field. As always, we look forward to following the presentations by a question and answer session with all of you, and welcome you beginning to put your questions into the Q&A section of the screen. We can go on. So first, just going over our logistics. As always, the webinar is being recorded and will be on our website shortly after the session ends. We also make the presentation slides available from the website, and those are available for you to download. Please use the Q&A button found at the bottom of your Zoom screen to enter your questions. That also allows you to upvote if someone else has asked a similar question, and make sure those questions rise to the top so that we can prioritize getting to those of most interest to the audience. Additionally, for questions we do not get to during the session, we do work with our presenters to develop a Q&A document and post that on the website, on our website, along with the other webinar materials. If you, in addition to having questions, if you have suggestions for us or resources you would like to share, please send those to us at our info@forefoundation.org. We'd also like to remind you to just do the brief give us some feedback right after the webinar closes. There's a very brief survey, but very helpful to us in knowing how we can most continue to contribute information that's useful to all of you in the field. FORE continues to expand our resources through convenings such as this, through the work of our grantees and the resources that they are building up, and our ongoing grant making through our RFP processes. You'll be seeing more about that in the coming weeks. But as always, if you're not part of our FORE family yet, we do encourage you to both go sign up for our updates through our website. Now, I'm very pleased to introduce our presenters and our panelists for today. We'll be starting with Doctors Sarah Hunter and Lori Uscher-Pines of the RAND Corporation, again, to present findings from their the study which we've supported them to conduct. Be followed by actually in a somewhat different order than presented here. Dr. Lisa Brown will present on the frontline experiences of her clinic. A clinical experience in Baltimore. Dr. Lawrence Brown will join us later in the hour to present on the experiences of the START retreatment and recovery centers in New York City. And then we will be very grateful to have both Mark Parrino, President of the American Association for the Treatment of Opioid Dependence, AATOD, as well as Dr. Betty Tai, Director of the Clinical Trials Network at NIDA, to provide commentary before we go to the Q&A. At this time, I'm going to turn it over to Sarah and Lori.
Great. Welcome everyone to our presentation. My name is Sarah Hunter and I'll be leading off the presentation today. My colleague Lori Uscher-Pines will also be co-presenting with me. Next slide, please. We were funded in early May to conduct a qualitative study of clinician perspectives on methadone service delivery and the use of telemedicine in opioid treatment programs in the US during the COVID-19 pandemic. More specifically, we wanted to explore practitioner experiences with methadone delivery in these settings and how telemedicine is being used in these contexts. Our colleagues Alex Dobb and Allison Over were co-investigators, and RAND's Institutional Review Board approved our study. Next slide, please. As many of you are aware, during the COVID-19 pandemic, opioid treatment programs, or OTPs for short, were granted new flexibilities around methadone dispensing and the use of telemedicine. More specifically, the Substance Abuse and Mental Health Services Administration, which oversees OTPs, released guidance that allowed states to request up to 28 days of take-home methadone doses, depending on patient stability. In addition, many payers, including Medicaid and Medicare, expanded reimbursement for telemedicine services, including video and telephone visits. Although these policy changes allowed for more flexible scheduling of methadone and decreased the requirements for in-person visits, little is known about how OTP clinicians responded to these regulation changes. So the goal of our study was to explore how clinicians working in OTPs were responding, particularly whether these new regulations were leading to changes in treatment delivery, particularly in the use of telemedicine. We were also interested in capturing clinician perspectives on how these changes affected treatment access and quality. Next slide. From May 14th through June 19th, we conducted 20 semi-structured interviews with clinicians approved to dispense methadone in OTPs. We collaborated with Medscape to recruit participants. Our interview protocol was designed to capture information about whether the OTP clinic had changed methadone dispensing practices during the pandemic, if they had any prior experience or were currently using telemedicine, and any challenges around using it. We also asked about the perspectives around future service planning, including the use of telemedicine. We used a rapid thematic content analytic approach to identify themes from our interviews. Next slide. This slide shows some information about our sample. We ended up talking to clinicians located in 13 states. 75% were physicians by training and 25% were nurse practitioners or physician assistants. Participants had a range of experience. About 50% had been in practice for less than 10 years. Next slide. First, let me walk you through some of our findings in regards to clinical care patterns. We found that almost all clinicians reported some changes in methadone dispensing procedures. That is the use of increased take-home doses for patients that were deemed lower stable. Also, a few clinicians reported encouraging patients to consider switching from methadone to a monthly injectable. Clinicians also reported increased use of telemedicine, which Lori will dig into more in a moment. We also heard that while in-person visits were still required for new admissions, many of the clinics stopped accepting new patients for a while early on in the pandemic while safety protocols were established. But by June, it seemed that most of the clinicians we spoke with had these new protocols in place that allowed for in-person visits to be resumed. Next slide. We also learned that there had been changes in the conduct of urine tox screens early on in the pandemic. While some clinics did not change their protocols, many stopped screening or screened less frequently to reduce infection risk. Clinicians expressed concern about these changes in their protocols. Next slide. On this slide, we provide a couple quotes from the clinicians we spoke with about changes in methadone dosing and switching medications in light of the pandemic. Now I'm going to hand it over to my colleague, Lori Uscher-Pines, to talk more about the telemedicine findings. Next slide.
Great. Hi, everyone. Excited to be here to talk a little bit about OTP's experiences with telemedicine early on in the COVID-19 pandemic. One of the first things that we heard is that most psychosocial services transitioned to telemedicine, as well as some medication management appointments. And the frequency of therapy typically changed. Some clinics reported no longer requiring therapy or having therapy less often, just due to access issues. We learned that prior to the pandemic, few OTPs were using telemedicine, although some clinicians that we spoke to had experience with it. So OTPs as organizations generally didn't have much telehealth experience, but clinicians perhaps might have in another role or in a prior position. We heard that group therapy was often stopped or provided less frequently, and several OTPs reported to us that there were technical challenges in running group therapy visits via Zoom, and they weren't comfortable having group therapy in person because of the desire to reduce exposure to COVID-19 or potential exposure. We learned that telemedicine remained less common for methadone patients than for buprenorphine patients. And this is largely the case because methadone treatment requires a more structured protocol and in-person observation. Also, when the pandemic began, there was an exemption to Ryan Haight, so buprenorphine prescribers could start patients on buprenorphine without a prior in-person visit, but those same flexibilities were not granted in the case of methadone. Also, telemedicine modality varied depending on both patient and clinician factors. We heard that generally clinicians preferred video visits, but despite that, there was a substantial use of phone across OTPs, and generally a pretty wide range from 20 to 90% of all visits across these settings were phone visits. And there was significant use of phone for a variety of reasons, including concerns about patient access to technology and issues with digital literacy. Next slide. So we have a couple quotes here that describe some of the clinician perspectives on barriers to telehealth. But Ken, I think we skipped an earlier slide. If you want to go back one. Great. So these are some examples of challenges that OTPs faced in implementing telemedicine, which was a key research question that we had. We really wanted to understand what were some of the barriers to not only getting programs started, but also maintaining programs. We heard a little bit about clinical capacity challenges, including lack of infrastructure. We spoke with one OTP, for example, that still didn't have Wi-Fi in the building. So you need to consider many of these facilities are resource strapped. So there can be a lack of infrastructure to support video visits in particular. We heard about concerns about patient privacy and HIPAA compliance, as well as security vulnerabilities. And we heard about concerns about technical reliability and the fact that it often takes more clinical staff time as well as administrative staff time to coordinate telehealth visits and to troubleshoot in case there are problems. Next slide. So we have some quotes here. The quote on the bottom really speaks to this point about how telehealth and implementing telehealth can really require more staff time and staff resources. One of our respondents spoke about how they had to extend their business hours in order to provide care in this new way. Next slide. We asked about how patients responded to the transition to telehealth. And providers told us that in general, patients responded positively. They reported that telehealth visits saved them time. They appreciated that it reduced infection risk and removed transportation barriers. They also appreciated the additional flexibility. However, some patients found it impersonal. They reported that they felt isolated and that they experienced technical problems in participating in telehealth. Next slide. We also asked the clinicians how they felt about telehealth and how they felt these interactions impacted the quality of the care provided. Clinicians told us that they felt that it was often difficult to assess patients' physical status or pick up on nonverbal cues. And we also heard about difficulties in building rapport, and this was especially an issue with phone visits. However, they did note some benefits to telemedicine. Some saw benefits to learning about patients' home environments, and they reported that often patients were more comfortable meeting in their own space. So quote on the bottom here really speaks to this issue of difficulty in building rapport because telemedicine as a modality can feel more impersonal. Next slide. So we asked about sustainability of telemedicine and clinicians' plans to offer telemedicine moving forward. Many clinicians agreed that telemedicine was potentially viable in the long term, but they did have some serious concerns about costs and liability. They felt that the most stable patients could benefit most from the flexibility and were most suitable for telehealth, but they were worried about changes in reimbursement policy after the pandemic ends, and they were also concerned about increased liability. And several of the clinicians that we spoke to did say that they plan to discontinue telemedicine services after the pandemic as a result of those factors. Next slide. So just to pick up on this point about liability, we have a quote here: "The chances of abuse of medication itself is so much higher. We just find it to be a huge liability on our part." So that concern about liability and safety may lead some OTPs to abandon telehealth in the future. Next slide. Great, so at this point we're at conclusions and policy implications, and I'd like to turn it back over to Sarah to wrap up.
Thanks, Lori. This slide just sort of summarizes some of our conclusions from our work. First, many clinicians that we spoke with reported dramatic changes in methadone dispensing and ancillary services like urine tox screening, psychotherapy during the first few months of the pandemic. But the changes in regulations didn't always result in widespread changes among all clinicians we spoke with. We also heard that there was a significant uptake in telemedicine, especially for patients receiving one-on-one support. Many clinicians reported significant barriers, however, due to clinic capacity to fully embrace telemedicine. In terms of access and quality, many clinicians had mixed opinions about the benefits of telemedicine in the context of the OTP setting and were unsure about continuing it post-pandemic. Next slide. So what are the policy implications of this work? Well, the changes in reimbursement policy was cited by clinicians as critical to supporting its use in the long term. Many clinicians were unsure about continuing it post-pandemic and suggested that permanent policy changes, especially in regard to reimbursement, would be necessary. Clinicians also mentioned that audio-only support was the only feasible telemedicine option in many cases and questioned if that type of support was enough in these settings. Next slide. In terms of conclusions and next steps, we want to mention once again that our study was limited and that we interviewed a small group of clinicians in a limited number of states early on in the pandemic. But what we did learn was that the increased regulation flexibility did not always result in major changes in practice. More data is needed on what reimbursement rate is necessary to support telemedicine use, for example. And clinicians suggested they would appreciate practice guidelines and other tools to help them make decisions in the virtual environment. Next slide. In terms of directions for future research, our findings suggest that more work is needed in several areas. First, whether the pandemic resulted in reduced access to methadone, and if that is related to increases in overdose rates. Second, whether these changes in practice, both in regard to methadone dispensing and use of telemedicine, should be implemented more broadly. If the changes have not increased risk for many existing patients, one example would be thinking about making treatment more accessible, perhaps through other outlets such as pharmacies. Third, since substance use treatment relies heavily on group-based modalities, and that appears to have been very limited during the pandemic, one might want to think about how this reduced group treatment has impacted outcomes to help prepare for the future. And finally, our study is limited in that we did not incorporate the views of frontline staff and patients. A lot could be learned by including these perspectives when considering opioid treatment policy changes. Thanks again. Feel free to reach out to me or Lori with your feedback. And with that note, I'm going to turn it over to our next speaker, Lisa Brown, the Managing Director at E-Psychiatriq in Maryland.
Hi, thanks for having me. Can you hear me okay?
Very good. Thank you.
Okay, great. Good afternoon. I would first like to thank FORE for inviting me to speak about the practitioner's experience. So I am Lisa Brown. I reside and have lived in Baltimore, Maryland my entire life. I work as a psychiatric and family nurse practitioner, practicing primarily in Baltimore City. I collaborate with facilities and outpatient clinics in the management of patients with co-occurring mental health disorder. As you may know, Baltimore City is no stranger in the fight of substance abuse. Substance abuse and prevention has been on the forefront of Maryland's ongoing effort to combat this crisis. Since COVID-19, we have witnessed a rise in the number of substance abusers and overdose. This is actually, when I was asked to speak, was, very important for me just to kind of give an overview of what my experience has been like. Next, a brief overview of the outline. We're going to discuss Maryland's rapid change of methadone delivery to maintain access and mitigate COVID-19, provisions that have been made in the methadone and buprenorphine guidelines during the COVID-19 emergency, and what we've done within my facility and the facilities in which I collaborate with to integrate telemedicine for opioid use disorder, changes to patterns and access, benefits of telemedicine, and some disadvantages that we've noticed. Estimated 20,000 people in Baltimore are addicted to opioids. In March of this year, we've noticed an increase of 2.6 of opioid-related deaths, which has definitely been an increase. In 2019, that's the first time in Baltimore City we've seen a decline in patients that have died from unnecessarily but overdose from opioids in over a decade. Minority behavioral health disparities already do exist in the city, both racial and social economic. So topping that on top of impoverished communities and isolation and financial stressors inadvertently, but unfortunately has resulted in decreased access to services to this population and increased substance use and abuse. This is a brief overview of some of the regulation and rapid implemented changes that has been handed down to us to implement within our clinics. I have worked closely with MAT clinics for most of my career, and I must say the implementation of these changes were very anxiety driven, not only for the patients, but for the staff. After Governor Hogan implemented an executive decision, our biggest hurdle was trying not to disrupt care. As you can see, for methadone changes, one of the things, and I outlined it for new patients or existing patients and some of the changes. For new patients for methadone, they were still required to come in person, and that's how they were implemented into the program. Buprenorphine, the providers were allowed to implement or do home induction. But one barrier to that was the practitioners already had to have the waiver in place. So it wasn't as if you could just come aboard and do it. You still had to do the 24-hour training to gain access in order to prescribe the buprenorphine. One plus was that existing clients that were already on methadone or buprenorphine, they were allowed to move forward and continue to have their services via telehealth. Another thing is the dispensing of the methadone. We were allowed to give a 14-day supply for less stable patients and 28-day supply for stable patients, and that was both for methadone and buprenorphine. The thing with that is that a lot of practitioners felt very uncomfortable with giving patients so much medication. So because of diversion, so that led to additional barriers and informed consent and a lot of regulatory issues, not only even though it was in place for the government, but just for the facility, just to, to ensure that we were doing the right thing. So some of the changes that was noted in our pattern of care, we did not stop daily screenings for new patients. Unfortunately, a lot of the providers that were in place were not very comfortable just saying, okay, we're gonna, do the induction. And there was really no real guidelines on that, nothing concrete. So for our new patients with methadone, we still did daily urines for a week, then every other day. And we proceeded as we felt comfortable. Many of these visits were, of course, all of these were in person. And as the dose titrated, we lessened the visit or we continued with the daily visit. We did coordinate with another clinic if we felt that there was some issue with diversion. And being as though they had provided point of care swabs or urinalysis in which that could give us immediate results, which we did not have access to. Our less stable patients were still screened for urinalysis weekly. Our stable patients were bi-weekly. One of the most important things was for documentation in the chart and during each visit, which we continuously feel as if we're making provisions through these consent forms, just trying to make sure we're covering all angles. Far as group meetings, initially they ceased. We did not move forward for approximately 2 or 3 weeks. Part of it is we had to set up access or different platforms. Zoom was one we mainly used because it allowed patients to use the telephone and video conferencing. We had to do a lot of test runs, but not only did we had to educate the patients on this, the staff needed lots of education. A lot of them weren't really used to this technology. And another platform we used was DoxyMe, but the issue with that one is that it's HIPAA compliant, but there was a lot of disruption in the platform when it was a lot of people were using it at the same time. Next slide. Each patient that came into our building, which led to other issues as far as staffing, they received a temperature check, the symptom checklist. Everybody was mandated to use masks. Unfortunately, we had to initially use a lot of our funding to provide masks for patients, but most important was the safety and concern of our patients and our staff. Staffing consideration was a huge issue. At the time, we were not looking to hire, but that's something we had to consider, being as though we wanted staff to primarily be dedicated to the temperature checks or monitoring or, the front desk, just to make sure that everything was covered. We allowed no more than 3 patients in the facility at a given time. And we also extended appointments to 30 to 60 minutes to give us time to facilitate the patient through the clinic. Some patients that were required to come to the office more often for urinalysis, at that time, they also completed paperwork. And we also, as time moved on, if they were coming in for urinalysis, we would schedule them to also to speak with their therapist or case management to make it more of a comprehensive visit so they didn't have to do these on additional days. We tried to eliminate patients having to wait outside, but if so, we also encouraged the 6-foot distance. We also extended our office hours, and we had open hours from 2 to 4. Some of our patients we did lose contact with because they were issued government cell phones, which has limited minutes, limited data, and pretty much no camera. So that was at least allowed for them to come in and to give us updated phone numbers and so forth. Another access was emails. A lot of our patients did not have emails. So part of that was educating them and trying our best to assist them in setting that up as well. Reimbursement continues to be an issue. On January 1st, Optum Maryland replaced Beacon in Maryland as the public health system administrator, which has not been flawless to begin with. So toppled that with COVID, There's been lots of billing issues and rebilling and denial of claims, which is something I know here in a lot of facilities are still working through. As mentioned earlier, some of the considerations we had to put in place is limited infrastructure. So on top of lack of access to internet service, bus services were even reduced or stopped to get into a lot of these facilities, particularly ours. So it was like, how do the patients get here? So that caused a lot of issues. Secure connections, telephones. The good thing of seeing patients within their home, you was able to assess their overall environment, which was a good thing. But that did leave that level of being uncomfortable of who's actually listening into the conversation. One thing we made all of the staff aware is that to notify the patient ahead of time that the lines were not secure and make sure that this was also documented in the charts. This is an ongoing barrier for some of this, but still room for improvement. Next slide. Not to say there weren't any benefits. As of today, we've had no cross-contamination. Our patients have been pretty much healthy, and so have our staff who also suffer with some chronic illnesses. So definitely to mitigate the risk of COVID-19 infection. We were able to synchronize live conferencing and was able to at least have access or to see our patient FaceTime or, video conferencing, which helped. It did provide some increased access to care because patients weren't just going without. The HIPAA good faith use of telehealth did make us feel comfortable in many ways that, if we were moving forward and if we did telephonic or video conferences, we did not initially have the consents in place that this was being covered. Another thing, patients and providers in rural areas with health disparities or ongoing health disparities. And it also provides some flexibility for evaluating and prescribing with the use of telemedicine. There are also some disadvantages, regulatory and legal requirements. Again, a lot of that is still a little gray area for us, even though we know on a federal level that this is covered, but as a practitioner, we're always feeling a little weary if we just do not have that informed consent. Technology consideration is something we're still working through with a lot of our clients. Again, making sure they have email access, leaving those open hours just in case they have to update phone numbers. For buprenorphine, the X waiver was a barrier. It allowed in-person visits for people who already had it, but unfortunately for patients that were new to the methadone or receiving methadone, we did not start seeing new patients again in June, which left a lot of patients without access to care. There's ongoing state regulation and insurance reimbursement changes that continuously change and, just trying more so for reimbursement. Lack of in-person peer support and case management was a huge thing. A lot of the times we feel like our clients come to the clinic or come to the meetings to support each other. And I feel as if they're definitely missing that. We are in informed consent and limited infrastructure, and patients and providers feeling comfortable throughout this whole process. The version is an issue that we are still dealing with, and what we do with that again is that we just increase urinalysis, point of care, and for these patients, we just still have them come to the clinic and we limit the amount of medication we give them. Practice guidelines consideration, ongoing support for the patients. We have initiated smaller groups via Zoom or DoxyMe, which has been great. The patients have really looked forward to that as they deal with their own, on top of substance abuse and mental health concerns during COVID-19. Defining the minimum essential personnel necessary to provide patient care safety. We're still figuring out the numbers. We have increased the number of staff that we've had. And our main goal is just safety for the staff and safety for our patient. And clearly defining roles and responsibility within specific areas. Again, we have some people that's designated specifically to when the patients come in to do the temperature and to document any symptoms they have had. And so that's important as well. And also, I think one thing that's often missing is the mental health needs of our patient with substance abuse disorder. I just feel as if that gap still hasn't been mended the way we need it to be. Our patients will not only come in for the substance abuse and group meetings, they will also meet with a mental health provider to assess those needs as well. So that's definitely something we will continue to work towards.
Great, Lisa, thank you so much. Really a terrific compliment to hear the real world frontline experience along with the research. We're going to turn now to our two commentators for this afternoon. I'm going to ask Mark Parrino to lead off. Mark, you make sure you're not muted.
Okay, can you hear me?
Yes, perfect. Thanks.
So we essentially agree with what's been reported by our associates at RAND. We gave you just recently our COVID-19 sort of report to SAMHSA, which we sent to them in the last 2 weeks. We also sent it to a number of state authorities. To be clear, the COVID-19 impact on OTPs was significant, unprecedented, as it affected other parts of the healthcare system. The first issue we had was fairly immediate in mid-March, where there were interrupted supplies of medication delivery to OTPs. So I communicated with all the major manufacturers. In addition to the DEA, there are flagging procedures when OTPs submit larger than normal orders. So we asked the pharmaceutical companies and the DEA to basically get past any of their flagging systems so medication could flow. We checked with manufacturers to be sure they had adequate supplies of medication. They did, and they were ramping up production of both methadone and buprenorphine products. The next major challenge was getting protective gear. A lot of the big supply houses did not recognize OTPs as essential medical services. We needed to get SAMHSA and ONDCP, the Office of National Drug Control Policy, to issue letters to the field, which we could use with supply houses so we could get masks and sanitizing equipment. It was very dangerous for a while because, as our colleagues already reported, we were not given any exemption in admitting new patients with methadone. So a number of programs had to consider exposing staff and new patients. And that became highly problematic in absence of having protective gear, masks, face shields, and gowns. Also, there were some initial challenges because the state authorities were asking SAMHSA for blanket exemptions. There was initial resistance, it changed, and then not every state, but many states did ask for blanket exemption requests. This was already alluded to with regard to 14 to 28 day supplies of methadone or buprenorphine. Generally, the programs worked quickly with the state opioid treatment authorities, otherwise known as SOTAs. We issued 3 advisories. The first came out on March 20th, the second on April the 9th, and the blog of March the 1st, summarizing our experiences. The reality was we were very concerned about patient infection rates, given patient comorbidities with HIV infection, hepatitis B and C, psychiatric comorbidities as well. Interestingly and favorably, patient infection rates have been relatively low, in addition to staff infection rates. I think this is accountable for the fact that the programs did move under the exemption opportunities to provide patients with more take-home. And the issues of telehealth, which I've already alluded to, well, we've been working to get telehealth services into OTPs. COVID-19 really did move this right up. And that was in conjunction clearly with SAMHSA, and they provided greater flexibility with the state opioid authorities. The problem here became the reimbursement authorities. Medicare responded quickly, authorizing up to a 28-day supply of medication and allowing programs to use telehealth in addition to telephone. It's already been alluded to. Keep in mind, many patients don't have access to either smartphones or emails, so the telecommuting had to be done mostly by phone. And we have a report also that indicates there's been mixed reaction. A lot of patients preferred the flexibility, and some patients preferred the in-person opportunities. Again, that's been alluded to. The findings that we have as we think going towards the future, we did not get a lot of reports of diversion or overdose. There were some, to be sure, but we did see an increase in positive toxicology reports. And we see this. Some programs did make it less frequent, but then they were all back on board pretty much by May. We have seen an increase, and it's been sustained, of fentanyl and heroin use, and that's been reflected in the toxicology reports. We are now gathering more data with the Denver Health and Hospital Authority. 75 programs have been completing surveys in 30 states. We will also working with the research team in Hopkins to do the very same in Baltimore. The future considerations probably are going to be that there will be more information and use of telehealth services. Also, I think there is going to be clinical consideration of providing extended take-home requests based on information we continue to gather. So I would say that the programs are now entering an adaptive phase, and I agree with what was suggested by our associates at RAND. That probably happened during June, but I'd say the months of March, April, and May were very rocky. Keep in mind the OTPs were never set up for social distancing. They were set up to treat a large number of patients at a site because it would be different than residential beds. Ultimately, it is remarkable how the programs did manage to adapt, how staff adapted, and there were many accounts where staff were reporting to work without masks or protective gear, and so they could continue new admissions or continue to respond to the needs of the patients. So I think that there's going to be a sort of cautious development and a regulatory issue. I can say that there was a lot of curbside dosing that was developed in programs, and a number of cities like New York City with the Department of Health actually provided fairly rapid response in terms of delivery of medication. So we'll certainly sift through more of the information, but our COVID-19 report to SAMHSA demonstrated clearly a lot of signs of adaptability, but the need for greater flexibility towards the future. Thanks for inviting me. That's my 2 cents.
Mark, thank you so much. I'm going to turn right to Betty to add her comments.
Hello, this is Betty
Yes.
Tai. Can you all hear me?
Yes, thanks, Betty.
Okay, thank you. Thank you very much. I am very much grateful for this opportunity. Thanks to Karen and the foundation. This is a great opportunity for me to learn, especially from the frontline providers, and also from a evaluation on the SAMHSA's relaxation of rules and telemedicine. It's really the 2 major areas in the NIDA CTN research portfolio. Let me start it. I know today is mostly focusing on OTP. I just want to divert a little bit, but I will come back. That is, in the past 5 or 7 years, that the CTN has been focusing its research of moving substance use disorders into the primary care. The reason is this expansion is necessary because, number one, there are a large number of patients who had SUD but does not have a place to go to receive the treatment. According to our friend Tom McLellan in his research suggesting that only less than 20% of patients who need treatment get treatment. The large percentage of patients, either they are, they need treatment, couldn't get it, or they're at risk to become addicted to a substance, but without knowing and without any preventive measures. And so we decided that, okay, maybe we should take on this challenge of trying to expand the treatment into medical settings, primary care. And yet currently actually our most active and successful area is probably into the ED. And also we have large studies into the healthcare system. A major component is primary care. I don't have to tell you, I'm sure you all know, the challenge is tremendous. Even like moving the buprenorphine into all these treatment, largely because you know, the lack of training, lack of waiver doctor, even doctor get the waiver, did not treat or does not treat opioid patient. But we finally made some inroad because of all the pushes from all the direction, plus with the federal opioid supplement research fund. When you started to have research and insurance companies started to pay for it, doctors will start looking at these patients, but you know, everything is very slow. I will come to OTP. When we are starting doing research in primary care, our goal is really to develop substance use treatment in using a chronic care model. In other words, we know that this is a chronic disease, but historically it's being treated as a acute disease, very early on just detox, and then later on put in maintenance and using the same kind of treatment dosage and format, and when patient get tired or patient feel they are better, then they leave, then they probably relapse. I'm sure you all know this more than I do. So we were thinking, okay, let's consider to develop a sustainable chronic care model. And while we were tackling this issue, several problems or challenges came. One is that when we talk about chronic care, we don't talk about just using the same treatment for a long time. So the treatment needs to be adjusted based on patient condition. So one way I think there's a lot for us to learn from the OTP is that my understanding is that you all treated the patient who are stable or who are the so-called the good patient with more flexibility. So the information we really need to know is from you, what are the criteria to describe a stable patient, number one. Number two, I know that now there seems to be more take-home formulation, take-home methadone. Do you think that if there are more of methadone, different dosage form. One is, you know, with higher dosage so that patient does not have to take a lot of pills. They can reduce the pills to a manageable numbers, number one. Number two, do you think a sustained release formulation for methadone is beneficial? And because that could really ease the take home. The third thing is that we really am thinking, how can we personalize the treatment? In other words, each person has other comorbidities, other issues, and that really get into their recovery from opioid use disorder. And how can we take all those into consideration? I think the most obvious one is depression, anxiety, or even, you know, infectious disease, these kind of thing. How can we accommodate that and make them into a one-stop shop, way of treating them so that they don't have to get a referral to go here, there. Most of the time, they probably don't go. And the other thing is we know that the abused opioid is getting more and more toward the synthetic ones because the availability. We know that the fentanyl probably is leading overdose agent. Do we know how to better treat that? Whether with methadone or buprenorphine or the induction procedure, and those things are probably could help the medical setting doctors to learn how to do this. And of course, I hear all the time we talk about reimbursement. And I think, when we talk about reimbursement, it goes to local community, and it became very complicated to tackle. Every state is different. Any recommendation would be helpful to identify the policymakers who can really make this thing happen. And that really is fundamental for combating this systemic racism that, this whole thing, this whole disparity issue was exposed so much more naked under COVID. So, so these are some of the things I think the medical setting doctors could learn so much from the OTP providers because they've been out there for the past 50 years. And I know that Mark has done a great job, and I'm on your listserv. I receive your publications constantly. And and we thank you very much. Yes, I think that's all I have to say now. Probably is over my time. I'm so grateful.
Very much appreciated, and that's a terrific set of questions. Thank you, and please stay with us as we move into addressing some of the questions. We have an incredibly robust set of questions, and we do appreciate that we're a little bit behind schedule. We will continue to run the webinar and answer as many as we can between now and until about 4:15. We hope many of you can stay with us. But again, if you're unable, we certainly understand, and we'll be posting a response, a Q&A document on the website with the other materials as well. But let's move right in and get some discussion with our panelists and with the audience. There were a number of, and I'll direct this one first to Sarah and Lori. In response to your presentation, questions about, if I followed correctly, it sounds like while some clinicians have switched patients from methadone to bup, many probably didn't, and overall methadone is less conducive to telehealth given the regulatory and other environmental issues. Can the presenter speak to how this might reinforce racial, socioeconomic, and other disparities in access to treatment? Terrific question, lots there. I'll ask the RAND team to lead off, and maybe Larry could add to that.
Hi, this is Sarah. Yeah, I really, that's a great question, and I really want to defer to the practitioners to address this, in that we don't know the extent to which clinicians were switching. But it's a terrific question about how that might reinforce disparities, given access to bup is much more limited, especially in urban settings. It wasn't something that we really could dig into given our research design. Lori, do you have anything to add to that?
No, I think that's right. We In general, did hear that methadone patients were receiving psychosocial services via telehealth. So it's not that telehealth wasn't used in this population, it just wasn't used as often for the medication management side of things. But those clinics that did give greater take-home doses probably had comparable telemedicine use for both methadone and buprenorphine patients.
Okay. Larry?
Yes, I'm happy, and please forgive me.
Larry, we're having trouble with your audio. Larry, we're having trouble with your audio. I'm gonna maybe, while we try to fix that, switch to Lisa.
So this was definitely an option, but as rapid as the implementation happened, it was invaluable in a sense that for a patient to go from methadone to buprenorphine, they would have to go through actively withdrawn, which is actively 2 days with nothing, which leaves the patient very fragile and vulnerable to either go out there and use, or the consequences that come with rapidly withdrawing from any opioid. So with that being said, we did not implement this because we monitor our patients a lot closer. There is some disparity definitely with getting buprenorphine, definitely in Baltimore City. There's a lot of pharmacies that do not have it readily or have to order it. We have a coordination with some pharmacies that we know readily have access to it, and this is where we tend to defer our patients to, just because they have it, not for any other reason. Another thing we like to implement is delivery services. Some of the pharmacies we do work with will deliver the medication, so we know that the patient does have access to it.
Great, thank you. We have a number of questions that relate to retention. Again, Sarah, Lori, maybe starting with you. Did participants in the study comment on whether in their experience the practice changes were impacting treatment retention, overdose, or other patient outcomes?
Yeah, I can speak to this. In general, this study was conducted early on in the pandemic. And at that time, we didn't hear many cases of diverse overdose deaths, but again, that was early on. And I think that, the best way to study these questions is to look at the quantitative data rather than explore it qualitatively. And, so our hope is that more quantitative data will come out on this in the future. Our team at RAND, in collaboration with researchers at Harvard, have been looking at what's been going on with medication for opioid use disorder during the pandemic. And we found that it's true that there are fewer patients receiving services, that new patient inductions were down in the early weeks of the pandemic. So, hearing that both on the qualitative and quantitative side. But we are seeing that those patients who are already engaged in treatment, their visits were relatively stable. More of them received telemedicine services, for sure. There was a huge growth in telemedicine, but overall visit volume in the early weeks of the pandemic was relatively stable. And so that's reassuring in terms of retention at this point. And both our research team as well as work by Epic Research Network has shown similar results.
Great, thanks. Any other comments on the issues around retention and related patient outcomes, early experiences?
This is Larry Brown. I'm back now. Can you hear me?
Oh,
clearly?
great. Yes.
So a couple of things with respect to the issue about the disparities, because our population is largely 90% Black and Hispanic. We did not see any disparity issues, and because of our population is so diverse, that may explain that. With respect to retention, retention was not any worse during the COVID pandemic, but we did have circumstances where clearly we had to change patient procedures and processes so that it wasn't, as I would call, patient-centered. And by the way, we started with telehealth, teletherapies, even telephonic, shortly in March because of the fact that we knew it was coming, but it took a great effort to get enough laptops because we were remote working our staff as well.
Really helpful. Lisa, anything else on retention and treatment?
Well, I can add, for some of our clients, kind of, I would say, quote unquote, fell between the cracks, just because a lot of it had to do with just not having access to us. A lot of them didn't have phones that were disconnected, no email. So we really much depended on the staff to do more of our outreach, which is the reason we had open business hours so they can just come up. We did see a decline, but a lot of the patients we do have in our program is really dedicated to their sobriety and their support system. They kind of come in and they look out for each other, which was really important.
Right.
So gratefully, a lot of them was checking in on each other to make sure they were okay, or reporting to us like, oh, I've seen so and such, he's gonna come up, and you know, there's a number change. But overall retention has been pretty steady.
Karen, can I add one more thing about retention
Sure.
of staff?
Yeah.
I think that where we did find a substantial hit to retention was in fact regarding our dedicated staff, either because of the fact that they were infected or had to be quarantined, and then that caused them and their families to be concerned. So staffing was already challenging pre-COVID. During the COVID period, it made it even more challenging to retain as well as to recruit.
Interesting. And actually leads into, we had a question specifically about, provider fears about exposure, staff provider fears about exposure to COVID, infection rates among providers. I wonder if others on the panel have any anything that they'd like to add there. Maybe Mark, maybe particularly starting with you. You have a sense across the different OTP programs and how the providers and staff were feeling in terms of COVID infection prevention?
Well, the staff were understandably anxious. The anxiety was initially driven by the fact that they thought that patient infection rates would be higher than they turned out to be. As I said during my brief talk, the fear was justified because they didn't have masks, they couldn't get protective equipment, and they were being compelled to admit patients with methadone whether they had masks or not. So what happened is the programs were forced into a very negative situation that if you're going to use methadone, you have to induct the patient face-to-face. Telehealth wouldn't be allowed. And the reality is that it's much harder to switch a patient from methadone to buprenorphine than the reverse. Research has shown this, clinical practice has shown this too. And there were programs where there were infection rates among the staff. And as Larry has already alluded to, that did create problems. And especially, there were some programs that had 4 or 5 staff infected. But fortunately, that was not a widespread phenomena. And I think we're going to see a separation with current infection rates. I've understood from programs that some of the patient and staff infection rates increased in higher impacted states, even when compared to the early part of the pandemic.
Okay. Thank you. Lisa, Sarah, was anything from your interviews on this item, on the topic of concerns about infection themselves?
This is Sarah. Yeah, I think we did hear from clinicians being concerned about that. Our interview started in May, so most of the clinicians we spoke with indicated that they, there was a moment of chaos in early March, but by the time we were speaking with people, most of the clinics had put into place safety protocols. They had obtained masks and other equipment, and just the resources they needed to keep the clinic open and safe for both staff and patients. I did speak to one clinician who their clinic had closed and had remained closed while they were trying to figure out how to get the resources to reopen.
Right. Thank you. A question about a future policy research. and suggestions about needing to focus on the types of infrastructure that would be required to make telemedicine more useful for practitioners and more feasible, such as what type of IT infrastructure is necessary, staff, what types of staff training, as well as adequate IT supports. I wonder, Lori, in terms of your work on this project and more broadly in terms of telemedicine, whether you had any comments on that and other work that's going on, perhaps, to begin.
Sure. I think these are very important questions. There tends to be this belief that telemedicine is relatively easy to do and potentially cheaper than in-person care. Your provider can be at home, and so there may not be some of the associated costs with physical space. I think that there's a lot we don't know, and our study showed that there are infrastructure challenges and technical challenges and logistical challenges that do prove to be costly and time-consuming for OTPs. So I definitely agree that this is an issue. So we need to do more research and really understand kind of what the level of reimbursement needs to be to incentivize the level of use we want, right? Is the goal for every OTP in the United States to offer telemedicine services? Is it the goal that some offer telemedicine services at some level? What is the appropriate level? Is that 20% of visits? Is it 50%? And for what? For medication management, for psychosocial services? So these are key questions that I hope future research is going to address. There was also a question in the chat about how clinics are preparing patients for telemedicine. Again, we pointed out that that can be very time consuming for staff to walk patients through that process, troubleshoot problems. We did hear about some clinics hosting patients for telemedicine visits. So those who didn't have devices could come in and do their visit, on an iPad in isolation. We heard, cases like that. In other cases of providers setting patients up with a buddy, for example, or a family member that can help guide them through the process. But we also were looking for examples of innovative strategies to help prepare patients for telemedicine, and would love to explore those going forward, because I think that's really key to sustaining this model.
Great, thank you. We have a question about the patient stability, and I think it also speaks to a couple of questions that Betty was raising. I wonder, maybe Larry, if you could speak to Larry and then Lisa on how you determined how patients fell into the categories of less stable or stable, or in terms of appropriateness for different lengths of take-home medications.
Certainly, and I can tell you that in one word, with a lot of difficulty. Because in the beginning, the clinicians had to take the risk of weighing the risk of COVID versus the risk of relapse. And most of our clinicians weighed more in the direction of preventing COVID than we did of preventing relapse. So that meant being even more liberal in the beginning, until we found out that there was some experiences that told us that we had to back off. And that meant doing it by patient. But initially, what we did in late February was in fact have all patients have a more liberal schedule. And even though we had some difficulty because we used to do oral fluid to assess clinical drug testing, we had to back off to urine, and we had to back off of that to even less frequency. So it wasn't until we got into the period for which we had enough PPE and enough time that patients felt comfortable that we could actually then say that using all the typical procedures and processes that we use to be able to say this patient seems to be stable enough to be once a week medication.
Great. Thanks. Lisa, anything you'd like to add on your experience with that?
No, I agree. It's very individualized based on your experience with the patient. Has the patient recently relapsed, stressors in patients' lives? And more collaboratively with, to me, I think a whole team effort. So just not the provider making the decision, but also consulting and talking with PRP workers and therapists and counselors so we can identify any stressors that may not be on the forefront. But that had a lot to do with our decision on how we move forward.
So sounds very tailored and personalized to the patient, but not necessarily an area where we have a clear framework or set of measures to base on. Yeah. Betty, is that an area that you're aware of other work that is going on the research side to try to shape some framework for measuring stability?
I think our insight from what we learned from the providers in our network is that the use cannot be viewed as the only criteria of patient's progress. In other words, abstinence is good, but the patient is not abstinent, but certain other function, quality of life, like they can hold on to a job, have a relationship, can make a job ongoing, and then that should also be considered. But we are in the process of developing consensus panels to look into that, and also to look into the longitudinal database and to see if there's any correlations with reduction in use and the improvement of quality of life or patients' functional skills and so on. So the research is ongoing. That's why I'm so curious to know how, you know, we evaluate patient and make a judgment.
Yeah.
Another thing I'm also very interested in learning is what is the optimum duration of treatment for maintenance, interventions. In other words, you know, is 2 years good enough, 3 years, 4 years, 5 years, you know? So these are the things that struggling with. Thank you.
Great, thank you. Thank you. I know we're, let me end with, there are a couple of questions related to what SAMHSA, from the perspective of, is there knowledge about when the changes of relaxed regulations due to the public health emergency might end? Is there any sense of an end date on those, or is that open-ended? And Mark, specifically whether the report to SAMHSA that you mentioned is one that's available. So I wonder, Mark, whether you might be able to speak to those two items. Is he still with us?
The report will be put on our website within the next 2 weeks. And
in terms of the public health emergency regulations, Mark or Ben?
in my recent discussions, I think SAMHSA will provide some notification to the field, hopefully 30 days. There's been no indication that that's coming to an end shortly. I think that's directly because of some of the high impact states still, and that you have programs within the states. What has happened, however, is some state authorities have returned more or less to a pre-COVID functionality on take-home medication, and some programs in states have been rolling that back to pre-COVID take-home related policy. So there's been no national recall of the emergency procedures. That'll be directed by Secretary Azar, and obviously all of the sub-agencies within HHS will follow suit. But we haven't heard anything as of yet.
Great, thank you, Mark. Very helpful, but grounding to also hear that even without that, there's some changes and some rollback. So again, as Dr. Larry Brown said earlier at the beginning, this is a continually evolving set of issues, and ones where, again, we want to continue to make sure that we're helping to make sure we're all able to learn from them and use the information to continue to improve access and quality of care. I really appreciate everyone who's been able to stick with us for a little bit longer period than we had scheduled, and thank you for all the questions, and want to finally thank our panelists one more time for a very rich discussion this afternoon. Hope everyone stays well and look forward to having another opportunity to meet with you soon. Thank you.